Hello, 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 madam. How are you?
Good evening, sir. Yes, sir.
Good.
Fine, sir. How are you,
Can
sir?
can you hear me?
Yeah, yes, sir. Yes, sir.
Okay, super.
Am
Can
I
you?
audible, sir?
Yes, madam. Can you open your PPT, madam?
Sure, sir.
Okay. Can you do the yeah, change the slide? Okay, perfectly all right, madam. So you can stop the sharing, madam. It is fine. Working fine, madam. Yeah. Thank you so much, madam. Coming online. How are you today? Your voice is not coming, madam. I think, can you please,
Unmute.
yeah.
Yes, sir. Yes. Now
Oh,
audible,
yeah,
sir?
perfectly all right.
Okay, sir.
Okay.
Still you are in college, sir?
Yes, madam. I do it here from here itself. It is much more
Oh,
convenient.
okay,
And
okay, sir.
yeah, actually today I'm staying back in the office.
Okay, okay,
So
sir.
I have a room here in the college.
Okay, sir.
So that
Nice, sir.
way I'll manage. Okay.
Sure,
So
sir.
please stay
Thank you,
online.
sir.
I will start sharing. I will ask other people to join. Okay.
Okay, sir.
Oh, okay. Yeah, so you can mute and you can also stop the video also if you like. Yeah. Good evening, everyone. Can you hear me? Hello. Good evening, everyone.
Yes, sir. Yes, sir.
Okay.
You're
Thank you
audible.
so much. Thank you so much for confirming. So let me just share the today's workshop. Okay. So can you see the brochure? Okay. Thank
Yes,
you
sir.
so much. Good evening, everyone. Today we are again back with the MPS webinar on untangling neuropathic pain, new insights and pharmacologic strategies. So today we have a very distinguished speaker, Dr. Kavita R. MD, PhD, Professor and Head, Department of Pharmacology, Sri Ramachandra Medical College. Ramachandra Medical College and Research Institute, Chennai, Tamil Nadu, India. So thank you so much, Madam, for accepting our invitation and joining us. I will introduce you in a few minutes. Before that, I would like to tell you that on behalf of Medical Pharmacology Society, I welcome all our participants and our speakers also. And as all of you know that Medical Pharmacology Society, founded in 2016, has been performing various activities, including book writing, book publishing, and conducting webinars, conducting conferences, conducting workshops, so many social activities for the development of our profession. Medical pharmacology as a important profession, we have been growing consistently and we have been performing well as an organization. It's really, I'm feeling great that, God has given us this opportunity to do this noble work for the development of our profession. I would like to invite each and everyone who is part of our program to join our Medical Pharmacology Society as life member and support our initiatives to the great to best possible way and help us to take our profession to the next level. So with this brief, introduction to our society, now I would like to share the CV of our distinguished speaker today. So let me just introduce our speaker. Okay, so thank you so much, Madam, for accepting our invitation. And our today's speaker is Dr. R. Kavita, MD, PhD in Pharmacology, and she is the Professor and Head Department of Pharmacology. And the institution is very well known nationally as SRNC-RI, Guru, Chennai. And we are very proud of you, Madam. And I'm seeing a lot of your activities right from Aspire and so many other, like recently, or I could see that some more programs and pharmacovigilance course you have conducted. I think under your leadership, the department has taken new direction, and I'm very much privileged to be associated with you in various programs what you are conducting, and we are very happy that you have accepted our invitation today, so that we can deliberate this very important topic on neuropathic pain. And just to give little bit more introduction about our Dr. Kavita Madam. She graduated from Hillpark Medical College and also MD Pharmacology from Dr. ALNTGIEMS, okay, and PhD from Maher University. Currently, she is working as professor and HOD at SRMC with 20 years of teaching experience in undergraduate and postgraduate teaching. She is also member of Medical Education Unit, member secretary of Postgraduate Curriculum Committee, Faculty Quality Council, and then IIEC Clinical Research Coordinator Committee, IEC member of various hospitals, and then coordinator of SRMC ADR Monitoring Center, AMC, and Medical Device Monitoring Center, that is MDMC. She designed and launched three certificate course in pharmacovigilance and metrovigilance, the first LMS value-added course at SRMC and RI, and chief editor of SRMC Pharmacovigilance newsletter and editorial member of Stride College magazine. She developed the Handbook of Comprehensive Drug Updates and authored 4 chapters. Thank you so much, madam. I received a copy of this book, and I'm sure this is very useful for various clinicians and also various postgraduates. And I also thank you for sending me a copy of this for our library. And she received 4 copyrights for innovative teaching technologies from the Copyright Office, Government of India, in recognition of her pedagogical excellence. She received first prize in oral presentation at Apticon 2024, AIMS Nagpur, first e-poster award at ARO International Conference, and then she also got the award, appreciation award by SRIHER for Medical College at Tamil Nadu as the Tamil Nadu coordinator, and she received Spotlight Award at NAPT. She published 55 research articles in indexed national and international journals, guided and co-guided numerous MD, PhD students, and served as examiner for MBBS, MD, and PhD programs across various universities. And she's also an organizer and resource person of various conferences and workshops such as Aspire, TREEMAT, GCP, CC. She is the life member of several scientific bodies, including ICS, NPP, and MS. So, with this brief background, I would like to, invite you to, start your presentation. We still have another 6 minutes, so that we'll exactly start at 6 o'clock. I'll hand over the mic in next 5-6 minutes. I request you to hold on so that we'll have the required number, like all the people who are interested to join our webinar, they will join. Today, as you know that it's our regular process that we channelize the total presentation both in Zoom and also YouTube, so that maximum people get the benefit, and we have the in Zoom only 100 people can be accommodated. Remaining people can be accommodated in YouTube channel. So I'm sure many more people will join, and they will encourage us to conduct more programs like this. Let me just introduce about. Let me just again play the our MPS achievement video, so that we'll spend some more time. Okay. So thank you so much for your patience. And now, ma'am, can you hear me?
Yes, sir. Can you
Yes,
hear me, sir?
yes,
Uh,
madam, I can hear you. You
yes,
can
sir.
please
Yes, sir.
take over. We really
Okay,
thank
sir.
you for accepting this. And I saw the PPT outline. It's really excellent, and I'm very much excited to
Yes, sir.
learn from you. Looking forward for the excellent lecture from your side. Thank you, madam. So now the stage is yours. Please go ahead.
Thank you so much, sir, for the kind introduction and for the opportunity giving me to present today as a speaker. And also, many congratulations to you for establishing a wonderful society, Medical Pharmacologist Society, and also making amazing initiatives in conducting conferences, workshops, and also launching important books. And I am very privileged to be a part of the programs you've been conducting, sir. Thank you very much for giving me the opportunity, and also best wishes to me to you to achieve more laurels and achievements, sir. And
Thank you so much,
soon
madam.
I'll
Thank you
also
so much.
join
Yes, madam.
shortly in the society. Thank you,
Yes.
sir. And I would also like to thank my respected guide, Dr. Vishwanathan, sir. Under his guidance, I did a PhD pharmacology, and the title of the study is the neuropathic pain. So
Oh,
that gives me strength and confidence to present today on this topic. And thank you once again, sir. And also thanks to dear participants, and will be with me for another 35 to 40 minutes. Thank you, sir. So
thank
without
you, madam.
much delay, shall I start my presentation, sir?
Yes, madam. Please go ahead. We are already 6 o'clock. We are on time. Next 1 hour you can take completely to discuss the neuropathic pain.
Is my slide visible, sir?
Yes, madam.
Okay.
Perfectly all right.
Okay, sir. Thank you very much, sir. So, dear participants, today's my topic is on neuropathic pain, and the title of the session is Untangling Neuropathic Pain, New Insights and Pharmacological Strategies. The learning objective of today's session is, at the end of the sessions, the participants, you will be able to define neuropathic pain and identify its key clinical characteristics and explain the etiopathogenesis and underlying mechanisms of neuropathic pain, and describe the current pharmacological and non-pharmacological strategies used in the treatment of neuropathic pain, and summarize the recent advances and emerging therapeutic options for the treatment of neuropathic pain. So we'll start with the definition of the pain. So pain is an unpleasant sensory experience as well as unpleasant emotional experience. IISP, that is International Association for the Study of Pain, so they have established the standard definition on pain. So it is an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. So it's replaced the old definition that unpleasant sensory emotional experience associated with actual or potential tissue damage and describes in terms such damage. So what they mean, the patient should report the pain, so similar to that of pain caused by the tissue damage. So then it can be defined as a pain. So we can go to the definition of the neuropathic pain. So pain initiated or caused by a primary lesion or dysfunction in the nervous system. So this is the older definitions, and we have more confusion terms like primary lesions or dysfunctions, so which over inclusive of other conditions like spasticity, muscle spasticity, or can lead to some other conditions which is not related to the peripheral neuropathy. So we want to make very much inclusive of the pathology of peripheral neuropathy. International Association study of pain. So they have brought out a new definitions. It's a pain arising as a direct consequences of lesion or disease affecting the somatosensory system. So somatosensory system is nothing but so that allows the perception of the pain, pressure, touch, etc. through the somatosensory fibers that will arises from the skin, muscles, and fascia. So they will, which includes the thermoceptors, mechanoceptors, chemoreceptors, etc. So when there is an altered sensations, altered neurotransmissions, so that sends a signals from this nociceptors to the spinal cord and the brain. So this results in the neuropathic pain. So the pain can be classified as a nociceptive pain and neuropathic pain broadly. So nociceptive is an appropriate physiological response to the painful stimuli. So it's like a protective system. So that warns the system. So whenever there is a noxious stimuli that has happened, it gets sensitized, and it's a physiological response to the painful stimuli. But neuropathic pain is an inappropriate response to a lesion in the somatosensory system. So nociceptive, they can transmissions or the pain can arise from the somatic, like musculoskeletals, maybe injury to the tendon, bursa, ligaments, fascia, etc. Or it can arise from the visceral organs or from the vascular regions, resulting in migraine, aneurysm, ischemia, etc. But neuropathic pain, so it's due to the lesion of the somatosensory system, maybe at the level of peripheral nervous system, or it may be at the level of lesion, maybe at the level of central nervous system. So few examples, the lesions following the peripheral nerve system, injury to the peripheral nervous system includes diabetic neuropathy, post-herpetic neuralgia, trigeminal neuralgia, etc. And lesions in the central nervous system arising to the neuropathic pains. Few examples includes post-stroke pain, spinal cord injury, and multiple sclerosis. So what are the differences in the characteristic of the nociceptive pain and the neuropathic pain? So nociceptive pain, so it will be an acute, and it mainly caused by the injury or the inflammations that affects the bones or the joints, and it will vary from moderate to severe pain, but it disappears when the injury heals. So mainly it gives us symptoms like sore or achy muscles, and patient may be anxious for a short time and may be optimistic about the relief from the pain. So it stays for a shorter time and it can be easily resolved. But neuropathic pain, so it has a tendency to become a chronic pain, and it will persistent, and mainly the cause so will not be a single cause. So and also it may have a multiple conditions that can rise to the neuropathic pain, and it can ranges from mild to excruciating pain, and it can last indefinitely and causes extreme sensitivity to touch. So we call it as allodynia, and the patients here may become depressed or withdrawn because of no relief from the pain, and may experiences the sleep problems, as well as can have anxiety and can affect the quality of the life as well. So here again, re-emphasizing that, so nociceptive pain, so it's a physiological state, and it is a normal response to the noxious stimuli. So neuropathic pain, so it has an abnormal receptors, and that maybe it causes, it's in the pathological state, and it can lead to chronic pain. And apart from that, the two difference of nociceptive and neuropathic pain. So based on the duration of the duration, so it can be classified into acute pain and chronic pain. So acute pain is a time limiter, so it can be 2 or 3 days or extend to till 3 months. And here the acute pain causes mostly will be known and results from the injury to the tissues and results with the healing. But chronic pain, so it's a more, challenging to treat, and it is very persistent. And when it persists more than 3 months, we call it's a chronic pain, and mostly the causes will not be known and continues even after the initial injury. And we have to treat not only the symptomatic, we have to treat the underlying cause, and also we can control the pain but not cure the conditions. So we have different types of neuropathic pains. It can be peripheral neuropathic pain, central neuropathic pain based on their level of lesions. And also you can see the anatomical distributions of the pain so that we can come to the conclusions of diagnostic of a peripheral neuropathic pain or central neuropathic pain. So some of the conditions we include under the peripheral neuropathic pain or acute inflammatory radiculoneuropathy, alcoholic polyneuropathy, chemotherapy-induced polyneuropathy, complex region pain syndrome, entrapment neuropathy, nerve compression, HIV sensory neuropathy, nutritional deficiency due to vitamin B12, painful diabetic neuropathy, phantom limb following the amputations, and post-herpetic neuralgia, and toxic exposure related pain, trigeminal neuralgia, post-traumatic neuralgia, and we have another condition called inherited neuropathy or inherited channelopathy resulting in erythromelalgia. So all these are the few examples of peripheral neuropathic pain. And multisclerosis, HIV myelopathy, Parkinson's disease, post-ischemic myelopathy, post-stroke pain, post-traumatic spinal cord injury, syringomyelia, multiple sclerosis, all comes under the central neuropathic pain. So coming to the prevalence of neuropathic pain. So chronic pain is a leading cause of disability worldwide, and everyone will agree upon this, and it is very highly challenging to treat these conditions. Neuropathic pain is particularly severe form of chronic pain, and it's a major contributor to the burden of chronic pain globally. So coming to the prevalence, you can see a wide range, so some percent to 10%, and due to the patients with spinal cord injury, they experiences a neuropathic pain in the range of 53% to 85%, and diabetic neuropathy from 20% to 30%, and in post-stroke pains, they can the prevalence range from 8% to 30%, and in cancer patients 20%, and chemotherapy-induced peripheral neuropathy. So 40%. You can see the highest percentage here, and one of the article has stated that 4 in 10 patients with chemotherapy suffers with this persistent severe neuropathic pain. And multiple sclerosis can have a prevalent of neuropathic pains from 25 to 85%. And it has been observed that the prevalence is higher in older people and also in the women, and also areas from the high social deprivations. So you could see the wide range of prevalence that is mainly because of different diagnostic tools and also distinct features of clinical features of the neuropathic pain, and many pathogenesis, multiple mechanisms that involved in the development of this neuropathic pain. And there is no one standard diagnostic tools to diagnose certain to the level of certainty in an, diagnosing neuropathic pain, so that it can lead to the wide range in the prevalence, and also it poses difficulties in coming to the diagnosis as well as in the curing the patient. So coming to the clinical features, so there's neuropathic pain characterized by spontaneous pain. So the patients will complain of burning, stabbing, electrical sensations like feeling, and you should know about the term hyperalgesia. So hyperalgesia is an exaggerated response to a painful stimuli. Allodynia is pain from normally non-painful stimuli. So even touching, slight touching, or wearing clothes can causes pain, heightened response of the pain. We call it as allodynia. And we can have the reduced sensation also. The patient may have a negative symptoms also, hypothesia and paresthesia, tinglingness, numbness, pins and needle sensations. So, and also the patient may, because of the chronic prevalent of this pain and sufferings, so the patient may have sleep deprivations, so they may have anxiety, depressions, and also overall the quality of life may be affected. So here you can see that positive symptoms includes paresthesia, allodynia, hyperalgesia, etc., and also cramps, fasciculations, excessive axial sweating. Negative symptoms in neuropathic pains that is characterized by numbness, tightness, hyposthesia, paresthesia, muscle atrophy, distal weakness, and lack of sweating or orthostatic hypotensions. So these are the complex signs and symptoms of the of patients who was diagnosed with a neuropathic pain. And this become a syndrome. And as I mentioned earlier, so because of this chronic nature and painful conditions, so it can affect the quality of the life and also can cause some psychological disturbances like anxiety, sleep disturbances, and also social withdrawal, isolations, and also can add that healthcare cost, etc. So it significantly impacts the quality of life, and also diagnosis and the management still remains challenging. So despite scientific advances. So coming to the pain pathway. So whenever there is a tissue damage, so what will happen? So the peripheral nerve endings, the nociceptors, that is the sensorized neurons, that will get activated. So here, so following this traumatized tissues, there will be a release of neurotransmitters like bradykinin, histamine, substance P, calcium gene-related peptides. So all these neurotransmitters, so that will transmit the signals. So here this nociceptors, especially the fibers like C fibers, unmyelinated fibers, and also A delta fibers, small myelinated fibers. So they get stimulated, activated, that transmit the signals. It's called nociception. So the signals get transmitted so to the dorsal root of ganglions, that is a first order neuron. So there, so that that increases the sodium channels entry and also increases the glutamate release, so that it get depolarization, and again it sends the signals to the spinal cords, and to that second order, it synapses with the second order neurons that is present in the substantia gelatinosa, and from there the neurons it means transmitted, opposite to that of the spinal cord, and it enters in the spinal thalamic tract, and it get synapsed with the third order neurons in the thalamus to the midbrain. So from the thalamus is a relay center. So here the third order sensory somatosensory neurons that has been transmitted to the sensory cortex, and sensory cortex, it sends the modulation, descending whether facilitations or inhibitions of the pain, and resulting in the pain perceptions by the patients. So this is the pain pathway, and so here you can see that pain, even though it's in diverse diseases, so they can operate through this common pain pathways. And also you should know that, because the understanding the pathophysiology is very important, so that you can understand the targets, emerging targets, or the diagnostic tools, so that we can easily detect and we can cure the patients with a neuropathic pain. And you can see that several neurotransmitters plays an important role in causing the pain. So we have excitatory neurotransmitters and prostaglandins, bradykinin, histamines, glutamate, and we have nerve growth factors and inflammatory markers, cytokines, chemokines, interleukins, and tumor growth factors, and dysregulations of the ion channels. So sodium channels and potassium channels and TRP vanilloid channels. So all this can lead to the pathogenesis of the pain, and also upregulations of the receptors also can lead to the glutamate receptor and P2XR receptors. All they can lead to the pathogenesis of pain. And we have the inhibitory neurotransmitters, so like GABA, the glycines, opiates, endogenous opioids, and serotonin, noradrenaline. So they take part in the descending inhibition pathway, and also they control the pain. So this is the normally happen. So when there is a nauseous stimuli has happened, so there is this have a process like transduction, transmissions, and also perception, modulation, and perceptions. So coming to the neuropathic pain, so you could see here, so many etiology plays here, maybe diabetes, metabolic diseases, ischemia, hereditary, nerve compressions, trauma, toxic chemotherapy can induce peripheral pain, HIV, herpes zoster can induce so immune mediated reactions. So all this can induce the neuropathic pain, and also it can cause the clinical characteristic, so of what we have mentioned, that painful signs and symptoms, and resulting in neuropathic pain. So what is the mechanism that lies behind the neuropathic pain? So here you can see at the level of peripheral fibers, at the level of spinal cord, at the level of the brain. So what are the changes has happened resulting in this pathology of the neuropathic pain? So in peripheral nerves, you can see that increased nociceptor sensitivity and ectopic firing. That means increased opening up of sodium channels. So there will be a spontaneous transmission of the signals, and this causes altered signal transmission or abnormal signal transmissions to the dorsal root ganglion. So where there is again increased excitability to the increase of the excitatory neurotransmitters like glutamate and tachykinin, etc. And also it causes wind up like situations. So it been highly stimulated by this high frequency, nerve firing from the nociceptors or from the afferent sensory fibers. So it itself it causes spontaneous firing. So even after the cessation of the C fiber transmission, and we call this as a wind up phenomenon. And further, it will stimulate the spinal cord neurons and causing hyperexcitability, and because of release of inflammatory mediators at the spinal cord and activation of the glial cells, and there is an increased synaptic efficacy, decreased inhibitory mechanisms. And at the level of brain, also, there will be release of inflammatory mediators, what we discussed later, and remodeling, reorganizations of the cortical neurons can happen here, and increase the discerning felicitations, decrease the discerning inhibitions. So that all this phenomenon, all this process can lead to the pathogenesis of neuropathic pain. Summarizing that, so it can have an ectopic activity. You can see that spontaneous discharge because of increased opening of the sodium channels, and peripheral sensitization will be increased because of the increase in the inflammatory mediators like TNF alpha, interleukins, beta, nerve growth factors, glutamate, prostaglandin, etc. That leads to hyperalgesia and allodynia, and also dysregulation in the ion channels, increasing opening of sodium, calcium channels, and decrease in potassium channels. All can lead to this pathogenesis of neuropathic pain. Apart from that, in the central mechanisms, so there will be activations of alpha beta fibers, that is a myelinated fibers, increase in the sprouting at the level of the spinal cord. So this can resulting in the spontaneous activity, and also can have a synaptic plasticity, glial activations, loss of inhibitions from the brain regions, periaqueductal cry, all can lead to the development of the neuropathic pain. So here, increased transcriptions, axonal trafficking of sodium channels with the reduction in the potassium channels, neuronal sprouting in the dorsal root ganglion, and changes in the gene transcriptions, activation of various kinase and proteins, and enhanced excitatory neurotransmitters also can lead to. Apart from that, so we can see that reorganizations. So neurons reorganizations at the central level. So you can see the sprouting in the next figure. So C fiber terminal atrophy and A fiber sprouting, all then can leads to neuropathic pain. And also different diseases may also have the common pathogenesis, but they may have more than one mechanisms causing this neuropathy. So if you take a diabetic neuropathy, you can see that so increase in the glucose level, so can involve it can cause oxidative stress, and also it can have several pathways like advanced glycolization in products, so that can activate the inflammatory mediators, and also increases the glutamate level, and also pathway, so that it can resulting in neuroinflammations. So similarly, insulin. So insulin resistance can lead to AKT pathway, protein kinase, phosphatidylate 3 kinase pathway to be activated involved in the ion channel dysregulations and neuroinflammations. So many pathways been suggested and by the earlier reports that could be the cause for this diabetic neuropathy. And CIPN, chemotherapy-induced neuropathy, so we can see that axonal degenerations, dysregulation of the calcium channels, and also changes in the neuronal excitability, neuroinflammations, oxidative stress can also lead to neuropathy, peripheral neuropathy. So some of the drugs mostly that is used as a first line of the drugs in treating solid tumors like platinum compounds and vincalcaloids, taxanes, paclitaxel, oxaliplatines, vincristines, all can resulting in peripheral neuropathy. So summarizing the pathophysiology of neuropathic pain, so you can see that different levels at the peripheral changes, what happens, spinal cord changes, cortical at the level of brain. So spontaneous pain will be generated. So that is mainly due to ectopic impulses because of the increase in the opening of the sodium channels and activation of the nociceptive or non-nociceptive fibers. And also if the spinal cord ectopic impulses of dorsal root ganglion, and cortical sectopic impulse of the thalamus. So here coming to the increase in sensitization, that is mainly because of the alterations in the ion channels. So upregulations of the sodium channels, especially sodium voltage gated Na 1.7, 1.8, etc. And also there is a loss of potassium channels. So to modulate this nerve injury, so all can resulting in the peripheral stimulation. So coming to the spinal cord sensitization at the level of spinal cord, again, the increased expression of the function of the calcium channels plays role here, and also increased excitatory transmitters, and so resulting in excitability of the spinal neurons, mainly through the NMDA receptor activations and tachykinin substance as an in neurotransmitters. And here another important mechanism is A fiber sprouting, so that mainly resulting in the allodynia. So here in the cortical level, in the brain level, so altered descending inhibition of the brainstem. So that's mainly modulated by the cingulated cortex and amygdala. So here, uh, I mean, decreased descending inhibitions. Or so here it should have an inhibitory role, but there is an alteration in this inhibitory role, so that it can resulting in more pain. And also it can limbic areas can leads to anxiety, depression, sleep problems, and the cortical reorganization also can resulting in the physiology of the neuropain. So with this about the definitions of neuropathic pain, clinical characteristic and mechanism behind this development of neuropathic pain, so we may have some question and answer related to what we discussed in the last 15 minutes. Okay. So I request an active participation from the delegates. So it's very simple questions. So can I see the chat box? Sir, can I ask questions? Am I audible, sir?
Yes, madam. You are audible.
Yeah. So which symptom is most characteristic of neuropathic pain? Can I get an option from the audience? A, B, C, D. Yeah, very good. Burning or pins and needle sensations. Very good. The patient reports pain on lightly brushing the skin with cotton. This finding is best termed as, yes. So whether it is hyperalgesia, allodynia, radiculopathy. So I could see A. Oh, very good. B. So I could see the right answer, allodynia. Okay, so allodynia is so the exaggerated response, painful conditions due to non painful stimulus called allodynia. So with the cotton, so cotton it will be light touch, isn't it? Patient reports is severe pain when lightly touched. So that is allodynia. So the mainly because of which fiber that plays a role here. Yes. Yeah, very good. Thanks for the answer. An electric shock like shooting neuropathic pain, mostly associated with abnormal firing. So here is say delta fibers. Which fiber is primarily responsible for the burning, persistent component of neuropathic pain? It's a very important one. Yeah, it's a C fibers. Ectopic firing in neuropathic pain is most commonly associated with ectopic firing. So what will be the right answer? A, B, C, D? Yeah, very good. Upregulation of sodium channels. Following peripheral nerve injury, which change contributes most to peripheral sensitization? Very good. Upregulation of TRPV1. So, vanilloid receptor and bradykinin in nociceptors. Central sensitization in neuropathic primarily characterized by. So, I could see how many correct answer I'll get. Yeah, very good. Loss of spinal inhibitory interneurons. Thank you for the active participations and the answers. And we'll move on to the treatment part. So we have completed the definition and clinical features and also the pathogenesis of neuropathic pain. And we'll move on to the treatment of the neuropathic pain. So before the treatment, we have to diagnose, isn't it? So what should be the goal of a neuropathic management? So we have to reduce the suffering of the patients. So we have to reduce the pain. That should be our first goal, objective of the management. And before that, we have to diagnose the correctly. So we will not have a single standard, gold standard diagnostic tools. We have multiple patient reported questionnaires tools, or we'll have a neurophysiological test we have to undergo. We have to do the biopsy, etc. So multiple things are there. Comprehensive assessment is required because of the complexity of the neuropathic pain. And but main our objective is we have to reduce the pain. So we have to treat the pain. So before that, we have to identify the conditions. So we have seen, no, so many conditions can lead to neuropathic pain, diabetic neuropathy, or chemotherapy-induced neuropathy, or like trigeminal neuralgia, anything. So we have to identify the conditions first, and we have to treat the conditions, and parallelly we have to treat the pain with analgesics. So we have to reduce the pain, should be our main first objective, and so that it can improve the physical functioning, day-to-day activities, and can reduce the psychological stress, and we can improve the overall quality of their life. But some of the conditions can be prevented, like herpes zoster, post-herpetic neuralgia can be by giving vaccines earlier. You can prevent such a situations, and by controlling the glycemic index in diabetic patients can prevent the neuropathy. So that so we can also have some preventive strategies in treating the preventing the neuropathic pain. So comprehensive assessment is required, and we have to. The history also plays an important role in identifying the cause, and also come to the definite diagnosis of neuropathic pain. So we have to ask the patients about the abnormal sensations. We have mainly the hyperalgesia, or allodynia, or hypoesthesia. So the specific symptoms should be asked, and also the anatomical distributions of the pain, their site, and their durations. Everything should be asked in detail. And also you have to identify the pathologies, whether the patient is a diabetic or has suffering with cancer, etc. And we can administer the questionnaire so that we can quantify, we can assess the sensory symptoms and signs, and also whether they already taken the response to the therapy. So if not responded, we can add on a therapy, or we can move on to the other next line of the therapy, etc. And we can have a questionnaire like health related quality of life, because quality of life is much affected with this chronic neuropathic pain. And also we have to assess the emotional disturbances, the disturbances is there, or any functional disability is there. So all this detailed history has to be taken initially, and have to follow with a physical examination, neurological examinations like quantum sensory testing, and also map the affected areas, and also can monitor the progress of the disease. And also we can administer the questionnaires, validated questionnaires. They are leads assessment of neuropathic signs and symptoms, LAN scale 1, and also Dowliner neuropathy, a 4 pain questionnaire. So among this different validated questionnaires, the European Neurology of Academy, that mainly they recommends this LANS and DN4 pain questionnaire. So we'll have different validated diagnostic scales, so that we can administer and also we can get the informations about the sensory signs and the symptoms as well as by the clinical examinations. So we can, of a way, we can come to the conclusions of the neuropathic pain. And these are the different scales with the symptoms, items, as well as the clinical examinations, and these are all are the validated questionnaires. So commonly we'll give the LANS and also Dowliner neuropathic 4 questionnaires and IDP pain questionnaire. So this is a LANS pain scale. So that includes pain, about the pain, signs and symptoms, and also the sensory testing we can do, and we can assess whether allodynia or altered pinprick threshold. If the scores exceeds 12, so we can tell that the pain is a neuropathic pain. And we have other scales like ID pain and also DN4 diagnostic questionnaire pains. This also we can have an interview and we can assess the sensory, clinical features, sensory signs and symptoms, and also we can have an examination and we can see the score, whether it exceeds the cutoff, and we can say that it gets neuropathic pain. And here you can see that, so when the patient comes with the pain, so you have to ask an elaborate history and identify the cause, and also the neuroanatomical distributions is plausible. Then you can say that it's a possible neuropathic pain. So if it is not, the pain distribution is not in a neuroanatomical plausible situations, then it's not unlikely to be a neuropathic pain. So first, it's in a level of possible neuropathic pain. So once we have come to this level of possible neuropathic pain, then you can go for the examinations like testing the sensory signs, and also whether it is in the same neuroanatomically plausible distributions by undergoing quantitative sensory test like laser evoked potentials, blink reflex, nerve conduction test, and somatosensory evoked potentials. So all this they can activate, they can assess the loss or gain of nociceptive or non-nociceptive fibers. And also when it is come to the conclusion yes, then it's said to be a probable neuropathic pain. So probable neuropathic pain, so here you can confirm your diagnosis by doing the diagnostic test. So what will be the diagnostic test? So here will be the skin biopsy. So it will be loss of epidermal nerves, like nociceptive fibers, C fibers, or A delta fibers, beta fibers. So you can say that, so it could be a neuropathic pain. And also corneal confocal microscopy also can identify the loss or gain of the fibers. So then we can come to the conclusions of neuropathic pain. So different level has been recommended, and it has been set by the ISP guidelines. It can be a possible, probable, or definite. So based on the history and comprehensive assessment of that sensory, signs and symptoms by electrophysiological test and confirmed with the skin biopsy, we can come to the definite diagnosis of neuropathic pain. And here you can have a, you can see that what the sensitivity, specificity of the different tools, and questionnaires, and also 83 to 90%. But nerve conduction test, we cannot come to the conclusion, but neuroimaging biopsy gives a higher accuracy. So come after diagnosing the neuropathic pains, and here you can see that, so it's not a single drug to treat these conditions. So we have to do multimodal, we have to follow the multimodal approach. So tiered approach, so treat the neuropathic pain. So here you can see that you can start with the least invasive therapy like psychological therapy, cognitive behavioral therapy, acupunctures, and physical exercises, lifestyle changes. So parallelly, you can add on with this topical medications, oral medications, injections. Not responded to all this non-invasive procedures, we can go for an interventional techniques. So some of the non-pharmacological treatment modalities includes cognitive behavioral strategies like meditations, relaxation therapy, acupuncture, rehabilitations, and cranial stimulations, electrical stimulations, nerve stimulations, that is called TENS. So this is a non-invasive procedures that also can be started with for treating neuropathic pain depending upon the patient's conditions. And here you can see the lot of drugs are available. So even few drugs have been approved by the FDA for the treatment of neuropathic pain. And we have a tiered approach. So we've been classified, the IASP is classified a different line of treatment. So first line of treatments for neuropathic pain that includes gabapentinoids. So gabapentinoids that includes gabapentin and pregabalin. So main mechanism of this gabapentin is that targets the alpha to delta subunit of voltage gated calcium channels. So when this being targeted and there is an decrease in the influx of the calcium ions, so reduces the depolarization and neuronal excitability so that it can be used in the treatment of neuropathic pain. So here another drug generation is a pregabalin is also introduced for the treatment of neuropathic pain. It has shares a similar properties, but because of their pharmacokinetic profiles, they've been not, predictable in their kinetics. So that could be the limitations of these gabapentinoids, and so it can, but still it's been approved to use in diabetic neuropathy and post-herpetic neuralgia. So the main adverse effects of this gabapentin is sedation, dizziness, and also concern with the use of these gabapentinoids is risk of misuse and abuse, especially with the pregabalin. So gabapentin commonly used in the treatment of diabetic neuropathy and post-herpetic neuralgia. So we have other drugs. So next to this is TCA, so tricyclic antidepressants drugs, and this mainly it targets the dissenting inhibition pathway. So that inhibits the serotonin norepinephrine reuptake mechanism, so that that increase in the serotonin norepinephrine level, and it has an inhibitory role on the neuronal excitations so that it can reduce the pain. But TCA preferably, not, even though it's kept in the first line, because of the adverse effects such as anticholinergic symptoms, because of dryness of the mouth and other anticholinergic properties. So it's been, depending upon the patient's conditions, the physicians can take a role in treating this use of amitriptyline or nortriptyline. And to avoid this anticholinergic adverse effects, now they prefer to go for SNRI, serotonin norepinephrine reuptake inhibitors. So they are duloxetine and venlafaxine. So it's been approved for the treatment of diabetic neuropathy, and it has a lesser adverse effects when compared to that of TCA. So you can see this gabapentinoids that includes gabapentin, pregabalin, and you can see that targets this alpha to delta voltage gated calcium channels, decreases the neuronal excitability, and it is considered as a first line of treatment. And you can see that it's an approved for post-herpetic neuralgia, and also it can be used by the physicians extensively in diabetic neuropathy. And main limitation is the intestinal absorptions, and half-life is 5 to 7 hours. Ideally, it has to be given 3 times a day, and up to 1800 milligram per day can be given. But here, some of the extended release are available, so it can be taken once a day after the dinner. And we have a prodrug of gabapentin also. So the main adverse effects is somnolence and dizziness are the common adverse effects. And it can also cause weight gain and vertigo, dry mouth, etc. And main concern is about the risk of misuse and abuse. So we have pregabalin that additionally has an anxiolytic effect. So patients having neuropathic with anxiety disorders, so we can prefer pregabalin. So other anticonvulsants also play a role in treating neuropathy. So we all know that first line of the drug for trigeminal neuralgia is carbamazepine. So mainly it acts through the sodium channels. So T type of sodium channels. And here oxcarbazine is much safer than carbamazepine. So other anticonvulsants also under investigations in treating neuropathic pain, lamotrigine and valproate. But still the risk outweighs the benefits. So coming to antidepressants in neuropathic pains, we have tricyclic antidepressants, amitriptyline, nortriptyline, clomipramine, imipramine, and SNRA, duloxetine, paroxetine, venlafaxine, citalopram, and mainly, so this will inhibit the reuptake, so that increases the level of this norepinephrine, serotonin, and have an inhibitory role on the excitatory neurons. And so when the patients have a coexisting depressions, we can preferably choose this antidepressants. And also can be used for the post-herpetic neuralgia, diabetic neuropathy. And also it can improve the insomnia. When patients suffering with pain can have a sleep disorders, etc. Anxieties that can also be parallelly treated when we use these drugs. And mainly it should be contraindicated with epilepsy, cardiac conductions, and heart failure. So the main concerns with the TCA is adverse effects with the anticholinergic effects that causing blood visions, constipation, dry mouth, orthostatic hypotension, sedations, sexual dysfunctions, urinary retention, etc. So anticonvulsant drugs for neuropathic disorders. So we have post-herpetic neuralgia. So FDA approved drugs or gabapentin, pregabalin. And for diabetic neuropathy, so we can use even some of the physicians, they are using carbamazepine and gabapentin, lamotrigine, and pregabalin. So, but here pregabalin is only approved by FDA for the use in diabetic neuropathy. Lamotrigine can be tried in HIV-associated neuropathy, and trigeminal neuralgia, still carbamazepine was the first drug of choice, and for the central post-stroke pain, lamotrigine. So these are all not approved by the FDA. So still gabapentinoids for the post-herpetic diabetic neuropathy, for trigeminal neuralgia, carbamazepine. But still the physicians are using based on the response in a patient. So coming to the second line. So when the patient is not showing response or the pain not relieved with the first line drugs, even one drug we can add on with another drug, another drugs. But still all the drugs the patient not responded, then we can move on to the second line treatments. So they are topical agents. So lidocaine. So lidocaine is nothing but lignocaine. So that blocks the voltage gated potassium channels, and patches are available, creams are available. So 5% patches can be commonly used for post-herpetic neuralgia when there is a localized pain. So we can prefer to go for the topical agents. Additionally, we can add on with the first line drugs for the neuropathic pain. So capsaicin, so that targets the transient receptor, vanilloid receptor, B1, causing desensitization, reduces the excitability of the neurons. So these two topical agents can be used. And we have opioid-like medications. So earlier days, opiates was in the first line because of the risk of dependency, abuse. So it's not been kept in the first line. So it is moved to the second or third line of management. So here, commonly not will go for the morphine except like that. So we'll go for the tramadol and tapentadol. So these drugs not only acts to the mu opioid receptor mechanisms, so it also acts through the SNRA. So that has a dual mechanisms, and mainly because of the sedation, dizziness, and risk of dependency. So we are not commonly use this drug. And along with the second line treatment, we can add on the complementary approaches. We can add the physical modalities and also the psychological therapy with cognitive behavioral therapy, acupunctures, and lifestyle modifications, which supports their day-to-day activities and also can improve the sleep and can improve the overall quality of the life. So here, so we have a topical lidocaine patch. So we can directly apply over the painful site, and also fentanyl patches also can be used for the pain. So here it's approved by FDA, and also it's demonstrated efficacy, and so very less likely to cause drug interactions or systemic adverse effects. So coming to the third line treatment for neuropathic pain. So we have NMDA receptor antagonist. They are ketamine, dextromethorphan. So ketamine also can be administered through the IV infusions, mainly that blocks the NMDA receptor, so that it's an excitated neurotransmitter that reduces the excitations and also blocks the by blocking the calcium channel. And it's been it is showing a good response in elevating the pain in diabetes. diabetic neuropathy as well as the post-herpetic neuralgia. So sub-anesthetic dose only we are giving 75 to 475 milligram. The main concerns with this administration of the ketamine is causing psychomimetic symptoms. So can cause the transient hypertension, hepatotoxicity, hallucinations, etc. And so that ketamine also can be given in case of refractory cases, not to the as a first line of the drug in the treatment of neuropathic pain. So we have dextromethorphans. What is has an advantage over ketamine is orally. It can be given orally, 20 milligram, and also it can be given intrathecally also. And this also similar to ketamine that blocks the NMDA receptor. And also another mechanism, it modulates the sigma 1 receptor. And so we'll have an opioid mechanism also, and also inhibits this alpha 3 beta 2 nicotinic acetylcholine receptors, so that it has a more effective. But in the practice or the clinical trials, it does not have more efficacy or when compared to that of other drugs used for recommended for neuropathic pain. So we have cannabinoids. So we have tetrahydrocannabinoids and also cannabinol. So here these two drugs, these cannabinoids attacks on the cannabinoid 1 and 2 receptors. And so one receptor mainly that activates the sodium channels and increases the neuronal activity. B mainly inflammations, neuroinflammation, B2. And all this non-selectively inhibits this both the receptors and can reduces the peripheral neuropathic pain. So here it can be given the cannabinoids can be given, but it should be under supervisions. And we have another drug called botulinum toxin. So botulinum toxin type A. So it's an intradermal injections can be given, and mainly that acts on the presynaptic neurons. That mainly that cleaves the SNAP25 receptor, so that it prevents the fusion of synaptic vesicles with the presynaptic membrane, and prevent the exocytosis of excitatory amino acids like glutamate, etc., so that it can reduces the depolarizations and transmission. So it can be used in post-herpetic neuralgia, diabetic neuropathy, trigeminal neuralgia. So it's in localized subcutaneous or intradermal injections. It also requires a specialized training, and the cost is higher. And it can cause pain and erythema at the site of injections. So ketamines, so through by blocking the NMDA and also reducing the calcium entry, so it can also reducing the neuroinflammations can relieve the neuropathic pain. So we have a cannabidiol. So cannabidiol, you can have multiple mechanisms modulating the endocannabinoid system and acting through the CB1 and CB2, so that reduces the excitations and also reduces the neuroinflammations. So we have a newer addition to our neuropathic pain treatment, that is ziconotide. Ziconotide is nothing but that inhibits the N-type calcium channel. So calcium reflux will be inhibited. So depolarization will be reduced and the signal transmissions will be reduced. And here this drug can be given intrathecally. So here you can see certain drugs like morphine and ziconotide can be given intrathecally to reduce the pain. Mainly it's given in some refractive or resistant conditions or as a complement with other drugs. But other drugs like clonidine, baclofen, bibivaquine also found to have an effective in reducing the pain locally and can be administered intrathecally, but they are not approved by FDA. So only either morphine or ziconotide can be given intrathecally to reduce the neuropathic pain. So concluding the pharmacological treatment approaches, so you can see we have to go by the tiered approach, and we can choose the first line drugs first, and also one drug not effective can add on another drug depending upon the patient's conditions and the response and their underlying pathology. So not treatable or not showing any response, so we can move on to the second line, then third line pharmacological pharmacotherapy. But still, whatever the study says, it needs a holistic approach with other complementary system and all. But pharmacological aspect plays an important role in treating the neuropathic pain. So we could see that we have seen that local anesthetic, lidocaine, topical analgesics or intrathecal analgesic, anticonvulsant, antidepressants, SNRI, NMDA receptor antagonists, gabapentinoids, all can have a role in treating the neuropathic pain. But when there is no response or in the refractive conditions, we can go for a invasive procedural treatment for neuropathic pain. So one is spinal cord stimulations. So TENS is a non-invasive. So the transcutaneous electrical nerve stimulation, just we are stimulating the nerves. We are keeping the electrodes on the scalp and we are stimulating the A beta fibers and C fibers, reducing the central sensitizations. But spinal cord stimulations is an invasive procedures. So we are keeping the electrodes, the epidural implantation of the electrodes, and that will send the signals and they will stimulate, activate the A beta receptor. So that will inhibit the C fiber so that they can reduces the peripheral neuropathy. So interneuronal transmissions will be inhibited. So like a gate control therapy they act and they can relieve the pain. And other interventions are we have intrathecal drug delivery, what we have seen with the ziconotide, and also we can go for surgical decompressions, etc. in case of refractive conditions. So these are our, the first one is the spinal cord stimulation, and the AB will be the transmagnetic stimulations, transcranial stimulations, keeping the electrodes on the scalp, and we can see that intrathecal delivery system and deep brain stimulations. Nowadays, DBS plays an effective role in treating Parkinson's disease, so that also can be given. That will stimulate the internal capsule and can pass the waves high frequency chronic intracranial stimulations of internal capsules and can reduces the pain excitations, neuronal excitations. So we have covered the treatment approach and how to do the diagnosis and how to confirm the neuropathic pain and what are the modalities we can use to treat the patients, how to go for a tired approach. So we have discussed. So we have can have some questions and answers to understand your attention. Okay. So according to the current guidelines, which class of drugs is considered first line for the treatment of neuropathic pain? Yes. Very good. So which statement is most accurate regarding the use of antidepressants for neuropathic pain? Yeah, can I have an answer for this? Yeah, very good. Hanisha A. Akila A. So here SNRI are effective in treating depressions with comorbid pain syndrome. Which of the following adverse effects is associated with TCA? Tricyclic antidepressants. Tricyclic antidepressants is a first line drug. No? Very good. Dry mouth. So because of anticholinergic activity. A 42-year-old woman complains of electric shock-like pain radiating along the right cheek, triggered by touching the face while washing. So what is the most likely diagnosis? Yeah, trigeminal. I think everyone would answer this. So what will be the treatment for this? Very good. Carbamazepine. Which of the following is common adverse effects of modern anticonvulsants like gabapentinoids used in neuropathic pain? Yeah, very good. C. So dizziness. Pregabalin reduces the neuropathic pain, very direct and question. So binding to alpha to delta subunit of voltage gated calcium channels. A patient with post-herpetic neuralgia is prescribed 5% lidocaine. So what could be the mechanism of lidocaine? So how does it relieve the post-herpetic neuralgia pain? By inhibiting the voltage gate sodium channel. Duloxetine relieves pain primarily by very good. B is the option, correct option. So thanks for the active participations and answering the questions, even though it looks simple, but just I want to know your understanding and the participations. And we'll just summarize the pharmacological approaches for treating this neuropathic pain. That includes gabapentinoids as a first-line therapy, and we'll have TCA and also SNRI, and second-line therapy that includes topical medications like lidocaine, capsaicin, and third line we'll go for ketamine, and also opioids has come to the second and third line of treatment. And so even though NSAID not, I mean, very effective in treating neuropathy, can be tried. And so coming to the recent research and the future direction. So as a budding pharmacologist, PGs, postgraduates present here, you can look for these targets and you can take up this as a research project. And you can see that, so all we have discussed the targets uh, for the in neuropathic pain. So NMDA receptor, opioid receptor, cannabinoid, and TRP receptors, TRPV receptor, and voltage gated sodium channels, calcium channels, potassium channels, acid sensing channels, and purinergic channels, serotonin adrenergic receptors, GABA receptors. And you can see this, the right side of the slide. So these are the new targets, you can think over it. And mitochondrial dysfunctions, histone deacetylizations, Wnt-catenin pathway, and acts on the sigma 1 receptor. So dextromethorphones that activates, I mean, blocks the sigma 1 receptor, because sigma 1 receptors, by activating the MAP kinase, it can result in neuroinflammations, and NMDA receptors, AMPA receptors, and also protein kinase C. So these are the commonly, I mean, identified targets for the pathogenesis of neuropathic pain. And some of the targets also identified. It's under the investigations. They are maybe in the phase 2 or phase 1 studies, and so that can be focused, can be considered for the future research. So they are TNF alpha, pro-inflammatory cytokines, interleukin 1, beta, interleukin 6, and also glial cell derived neurotrophic factors, GFR3 receptors, and glial cell activations, phosphodiesterase plays a key role. So we can look for the inhibitors, pentoxifylline ibudilast, and also HCN channels, and so that it targets the nerve growth factors. So we have one monoclonal antibiotics that has been approved, that is tanezumab, and targeting the substance P in the dorsal horn and targeting the release of substance P. So we can target the NK1 receptor. So we can just check whether abripihant can have alleviate the neuropathic pain. And also we have tetrodotoxin sensitive resistant sodium channels as a target, voltage gated calcium channels, potassium channels, and CRGP receptors, alpha adrenoreceptors, even the clonidine also, some of the trials it's proven that it can relieve the neuropathic pain. It's by centrally acting as an alpha 2 agonist, and facilitating descending inhibitors like targeting the mu receptors, adenosine receptor. So recently this receptor has been adenosine A1 receptor been identified, and that can be targeted so that it can have a value in treating the neuropathic pain. GABA, serotonin, adrenergic receptor, cannabinoid receptors, NMDA receptor, TRPV, we know that, but M6 and A1 also plays a role in causing neuropathic pain, that also can be targeted. And purinergic receptors, bradykinin, TLR4, toll-like receptor, chemokines, connexin 43 also can be targeted. So nowadays they move on to the gene therapy and mRNA, RNA, and also the calcium releasing activating channels also play a role in neuropathic, that also can be focused for the investigation and for the future research in reducing this neuropathic pain. So these are the emerging pharmacotherapies. So ambroxol, bromelain, melatonin, N-acetylcysteine, so that is the precursor of glutathione, and bromelain, that is obtained from the pineapple plant. So that even though it's been used in digestive, that has a play of role in reducing the oxidative stress and reducing the neuroinflammations. So melatonin, that regulate the circadian rhythm and also can reduces have a role of reducing neuroinflammations, and N-acetylcysteine, that acts on blocking the sodium and potassium channels, and we have ambroxol, so that also regulates the dysfunctional ion channels, and we have others phytochemicals like resveratrol, that is obtained from the grape juices, curcumin. So all this have proven that can reduces the neuropathic pain. And so many phytochemicals are come in play in alleviating, and they in the preclinical studies, and they are proving that they can reduces the neuropathic pain. And I have chosen the flavonoids. So under the guidance of Vishnuadhan sir, so I did my PhD and completed. So these are the few publications of my work. So structurally related compounds, flavonoid compounds have been chosen, and we assessed in the paclitaxel induced neuropathic mice model. And the main novel thing is, so here we have seen the mechanisms involved, like GABA and potassium, ATP sensitive potassium channel, and adenosines. So the adenosine involvement we could identify, and this flavonoid have a role in this by elevating the neuropathic pain. So these three compounds, among the three compounds, all the compounds have an effect in elevating this neuropathic pain. And among this, 7,3-dihydroxyflavone is more effective, and shows a significant improvement in reducing this neuropathic pain. So with the last question, so can I get the answer for this? Which monoclonal antibody is being explored for neuropathic pain by neutralizing nerve growth factor? So tanizumab. Thank you, faculty, the delegates, for the active participation and answer. For the patients listening for this 15 minutes to 1 hour.
Thank you so
Any
much,
questions?
madam.
Yes,
It
sir.
was very nice, actually. I
Yes,
could
sir.
see that you started from the anatomy and neuro pathway, and then
Yes, sir.
neurotransmitters and pathophysiology, and then finally treatments already available, and then going towards the latest research thrust area, and the molecules in the pipeline. And also you touched upon your research paper also. Very nice. I think one of the best presentation we had till now. So I
Yes.
appreciate your detailed presentation and detailed work. And also I appreciate your engaging, ability to engage the participants through question and answer session. And it was really nice. We have two questions
Yes,
actually
sir.
coming from some participants. You mentioned
Yes, sir.
what are the brand names available for 5% lignocaine patch? Are they available in the market? And also, is there any oral ketamine preparations available in the market? So, can you please throw some light on this if possible?
Yes, sir. Excellent question, sir. Is it available, sir? Lidocaine patches is available. 5% patch is available, and
Hmm.
it is been commonly used in post-herpetic neuralgia.
Hmm.
And also, so along with additionally some first-line drugs, so they are adding this localized pain relieving. Approaches also. So lidocaine patch is available,
Yeah.
and it is commonly used by the neurophysicians.
Yeah.
And regarding ketamine, so ketamine infusion as of now, so with my knowledge, so whatever I refer the articles, so I not come across about the oral preparations or oral availability of ketamines.
Yeah, actually, like
Maybe I'll
we,
refer and
I
tell.
can, yes, ma'am, that is good actually. But
Yes, sir.
we had a doctor coming from Niman as
Okay,
a
sir.
guest speaker, and
Okay, sir.
he really expressed his difficulty in managing some patients with depression. In
Yes, sir.
such cases, actually, he mentioned that he had a methodology to prepare his own ketamine oral preparation, actually.
Oh, great, sir. Yes, sir.
Since NIMANS is a premier institution and they are, they are able to use their expertise and then manage the oral preparation.
Okay, sir.
He also
Oh,
expressed his, like unhappiness for not having the oral ketamine preparation in the market, for not having the oral ketamine preparation in the market. Mainly because I don't know what is the reason, because it is a anesthetic and it is having it requires a lot of monitoring. So
yes.
providing the oral preparation can have maybe other issues. And also it is also having like the misuse also, the possibility of misuse
Yes, sir.
also. Maybe that is the reason. And also what he mentioned, like we even asked, yeah, he mentioned that the ketamine is a very good drug as far as treating the depression, especially severe depression patients.
Yes, sir.
So for that purpose, they wanted to use ketamine oral dose, and but the reason why the people also not producing, I don't know, maybe users are less, yeah, and expertise is not available for utilizing this medication for the purpose of oral administration and treating. Because they can be severe depression cases, and they have to, manage them in-house inside the hospital and keeping it available. And also maybe marketing issues will be there. So these
Yes,
are
sir.
some of the reasons what we got from them that
Yes,
they are
sir.
not making it available or not available for the purpose of oral administration. So, is there any
Thank.
other questions? Anyone? Anyone? Any other questions available? I think everyone is expressing their happiness and thanking you.
Yes, sir.
Uh, on behalf of Medical Pharmacology Society, I really appreciate your work and thank you for presenting your real work here as a PhD student. You have done extensive work in this neuropathic pain, and I congratulate you. And also, please convey our pranam to your guide.
Thank you, sir.
Without the guru, I think it is not possible to achieve so much. And we are
Definitely, sir.
really indebted to your guru also. I thought, I'm just thinking we should have had him as to chair this the session, if
Yes,
possible.
sir. Yes,
So
sir.
since we don't know him and I don't know we did not know the background of this. So I feel, like maybe you would have honored him also with a chairperson to chair opportunity to chair this session. With this,
Yes, sir.
we are really thank you for this.
Thank you, sir.
And can I share my screen, madam? Maybe if you can end your screen.
Yes, sir. Can I stop sharing, sir?
Yes, ma'am. Yeah,
Yes.
I will. I would like to present the certificate to you on this important presentation.
Thank you, sir. Thank you very much for the opportunity and for the kind words of appreciation,
Yes,
sir. Thank you very much, sir.
thank you so much, madam. This
Thank
is
you very
the
much.
certificate of
Yes.
appreciation from the
Yes, sir.
Medical Pharmacology Society. Hope you are able to see the certificate.
Yes, sir. Yes, sir.
Yes.
Yes, sir. Thanks a lot.
Thank you so much, and I will send you
Thank you,
by
sir.
email. And
Yes,
I'm
sure, sir.
thinking that I would like to invite all the MPS webinar presenters to our conference so
Yes,
that
sir.
we can have a special appreciation during the conference also. So MPS Con 2026 will be held at the City Timer in Bangalore. So most probably in May 20, 21st, 22nd. We have not yet finalized.
Okay,
We
sir.
will announce. So
Okay,
we
sir.
look forward for to see all the presenters and also chairs and also the all the participants who are participating online. So hope we will have an opportunity to meet each of you and greet each of you. So looking forward to see all of you. Thank you so much, madam, for the
Thank you, sir.
all the good work you have done. I appreciate you, and I would like to tell you that you should continue what you are doing. It's really great work. I think
Sir.
it should not be an over appreciation, but I am really from my heart. I congratulate you for taking the Department of Pharmacology SRMC SRMC I would say it
Yes, sir.
is a very nice. You are doing good, great leadership going on, and we look forward for next. Most probably, I think if I'm correct, Aspire will come soon. That's what I'm expecting.
Yes, sir. Yes, sir.
Okay.
Mostly in the month of April, sir.
Yeah. So you will start gearing up
Yes,
with the
yes,
Aspire
sir.
soon. Because
Yes, sir.
last year I think we participated the same time.
Yes, sir.
So
So,
I suggest all the youngsters who are attending this program to look forward for Aspire very soon. Okay, so SRMC conducts very nicely. It was very nice program actually. Last year I was part of as a resource person. It was very nice program and definitely especially for the postgraduate students. So hope to see you either at your office or at our office. Looking forward.
yes, sir.
Thank
Definitely
you.
say thank you, sir. Thank you very much for your kind words and
Okay.
appreciation, sir. And
So
also
with this,
thank you to you for bringing this MPS platform and organizations and doing so many noble activities and encouraging the budding pharmacologist and to enhance our fraternity, medical fraternity. Thank you very much for all your activities and including us. And we feel so honored and privileged to be part of this program. And so keep coming for our Aspire also, sir, as a speaker and so that we can share your
yes,
valuable insights with the PG's postgraduates. Thank you,
yes,
sir. Thank you very
thank,
much for the opportunity.
yes,
Thank you,
thank
dear
you so much.
delegates.
Thank you
Yes, sir.
all the participants. And if anyone want to say a few words, if anyone, maybe then one or two people. Otherwise, we have overshooted the time, so we can close the session if nobody else to talk. Okay, thank you everyone. There is no hands raised. Looking forward to see you all in our